Hey guys, welcome to case 3 in our case series. Let's just hop right into it. Alright, so we have a 70-year-old man, comes for evaluation of a neck mass with weight loss. He's noticed a growing mass in his neck for the past 3 months. It is not painful. He also has intermittent abdominal pain. He's lost 10 kilograms over the past 4 months. Sometimes he wakes up in the morning sweaty. He appears pale, pulse and BP are normal, but he has 38.1 Celsius fever. He has a painless golf ball-sized mass in the anterior triangle of the neck. A biopsy shows large cells with bilobe nuclei, CD15 and 30 are positive. Serum calcium is 15 milligrams per deciliter. PTH is 42. Which of the following is the most likely explanation for this patient's labs? So I'll let you go through the answer choices on your own. You can pause the video here and pick an answer, and then we'll discuss this case in more detail and each of the answer choices. Okay, so now that you're back, let's talk about this. So what does he have? He has a painless neck mass, okay? He also has abdominal pain and high calcium. Remember, high calcium, stones, bones, groans. So that matches our abdominal pain here. Sometimes they'll give you details, but separate it out in the paragraph like this, and it's up to you to kind of connect them. Okay, he also has fever, right? Fever is one of the classic, It's a classic B symptom. So just remember that, and we'll talk about his biopsy results right now. So he has a 15 and 30 positive bilobe nuclei mass. What does that make you think of? Obviously Hodgkin's lymphoma, right? So here's our Reed-Sternberg cell. Essentially, they told you the bilobe nucleus cell was this Reed-Sternberg cell. And also another thing we're looking at is the PTH level. So calcium, is it appropriate with the PTH? So our calcium's high, and if our calcium's high, our PTH should be what? It should be low, right? So it's appropriately low. Here's our normal PTH range, and here's our current PTH level. So something's raising this calcium, and then our PTH is appropriately responding. So what's going on? What's the right answer choice here? And if you picked the answer choice B, boom, you would have been correct. So let's go through each of these and why they're right and wrong. Okay, so essentially this question is talking about hypercalcemia and malignancy, and we'll see how each of these answer choices mentions how you can get hypercalcemia in different versions of malignancy. So not just in Hodgkin's lymphoma or non-Hodgkin's lymphoma, which are similar in this case. Both of those would have caused answer choice B to be right, but also in different kinds of cancers and how they can cause hypercalcemia. So hypercalcemia, often seen in cancer patients, and in different scenarios based on the type of cancer. So let's go through the answer choices. Osteoblastic metastasis. Why is this wrong? So you can have osteoblastic metastasis in lymphoma, okay, but usually this is not associated with hypercalcemia because it's osteoblastic. We're building bone. We're taking it out of the blood, right? So the calcium, if anything, would have been decreased. Then there's no bone or back pain, suggesting no bone involvement, okay? So usually when you have osteoblastic, the bone is growing, it's pushing on nerves, you're going to get kind of pain in that area, right? It's destabilizing the bone too. And osteoblastic lesions, where are they commonly seen? Prostate cancer, that's the big one here. And also you can see them in small cell lung cancer. But if I was to pick to memorize one of these, prostate's your big boy right here, okay? Osteoblastic cancer, prostate builds bone. And you'll usually see this in the spine. Next answer, and are correct. Increase 1-alpha hydroxylase activity. So you remember that 1-alpha hydroxylase, it's used in the production of vitamin D, right? It's in the kidney and it makes vitamin D. So this causes ectopic vitamin D production, right? Vitamin D3s are active form. So lymphoid tissue actually, right, as is overproduced in our Hodgkin lymphoma, it has 1-alpha hydroxylase activity. And this increases our vitamin D production, or our mature vitamin D production. And hypercalcemia is a result of this because we have increased intestinal absorption and renal reabsorption of calcium, right? And high calcium, low PTH, as we talked about. Do you know another disease where 1-alpha hydroxylase is increased? Right, sarcoidosis, right? So in sarcoidosis, the granulomas overproduce this 1-alpha hydroxylase. So that's just another key tidbit for you. Ectopic Pth production. So PTH-related protein, or PTHrP, is produced in cancers, and it's another cause for hypercalcemia in cancers. So what happens? Tumor cells produce this PTHrP, and it's also known as humoral hypercalcemia of malignancy. It's a paraneoplastic syndrome, so it's associated with cancer, and it increases bone resorption. So PTHrP essentially acts like PTH, but if we were to do a lab to detect the PTH level, it wouldn't be appropriate because PTHrP is not the same as PTH, especially in lab detections. So they'll often try to trip you up. So they'll give you a calcium and PTH level that don't match, and that's because the PTHrP is doing the job of PTH. So just watch out for that. If they trip you up, they'll give you a PTH level in a PTHrP. You just have to notice that there's some other component here doing its work for it. And again, so it works in the renal cells, causes increased absorption of calcium and an increased phosphate excretion. So they would have given us some more phosphate labs if they were more hinting towards this. And essentially, humoral hypercalcemia of malignancy is associated with small cell carcinomas, okay, or squamous cell carcinomas. Sorry. So squamous lung cancer, that's the big one here. But if they really wanted to trip you up, they'd give you a squamous cancer of the head and neck. So not just the lung, but the head and neck can also do this. Watch out for that. And we also have renal, bladder, breast, and ovarian cancers, which can do this. But if I were to really just memorize one, I would do squamous cancer of the lung. That's our main culprit here, and that's the most tested one, as far as I've seen. Then we have vitamin overdose. So vitamin overdose, let's say you're taking a lot of vitamin D, can cause this kind of picture. But would a vitamin overdose produce large neck lump and fever? Probably not. So it would produce similar labs, that's true, but it wouldn't produce this large neck mass and the sequelae we're seeing. So that's how we eliminate this answer. Then osteolytic metastasis. Now this is another cause of how cancer can cause increased calcium, right? Osteolytic, so it's breaking down bone, causing hypercalcemia. Tumors produce increased IL-6, which can cause bone resorption because it stimulates osteoclasts. And then we have this potentially occurring in lymphoma. But if we're having breakdown of bone or remodeling of bone, we're most likely to get some bone pain, which is not seen in this patient. And the most common cancer here is multiple myeloma, right? So osteolytic, multiple myeloma. If we go back to our answer, osteoblastic, okay, that is prostate cancer. So hypercalcemia of malignancy. What are the three things we want to remember? We want to remember squamous cell carcinoma with PTHrP, 1-alpha hydroxylase with Hodgkin's and non-Hodgkin's lymphoma, and then osteolytic lesions with multiple myeloma. So those are the three cancers that are mainly associated with hypercalcemia that I would remember for this case. All right, so I hope this little case helped you out, and I'll see you guys in the next one.